Hello, dear doctor. Good morning and welcome to MRCP RFA Medicine. And I'm your mentor, Dr. Abdul Khalik AK for MRCP Medicine UK and MRCP Ireland. And welcome to an exciting session of an skin disorder, which is commonly tested in our MRCP exam. And I have seen a lot of students find difficulty in differentiating the different type of pemphigus. So that's why I selected this topic to present today. So in this session, we will do pemphigus. We will know the differential diagnosis of the pemphigus and the management of the common type of the pemphigus vulgaris. So in this session, we will talk about the different type of the pemphigus, as I said. So the pemphigus is a disease, is a skin disease of a eruptive bullous eruption of the skin because of the antibodies against the adhering protein in the skin layers. So according to that, we differentiate them area of involvement of the skin, antibodies, and their immunofluorescence. So these are the three things on the basis of which pemphigus is differentiated into different types. We have quite a few of different type of pemphigus, in which include pemphigus vulgaris, IgA pemphigus, pemphigus herpetiformis, pemphigus vegetans, paraneoplastic pemphigus, and pemphigus foliaceus. If I'm not wrong in saying that, if you go through these slides, this is an excellent slide to understand all the different types of pemphigus. If you see here, so first of all, if you see the first slide's first column of this picture, which showing you the clinical photo schematic diagram of the blister, histology, and direct immunofluorescence. The first of which says PF is pemphigus foliaceus. So here, if you see the first picture, which is showing the back, so it means that this is a disease which only involves the skin. And if we go on the bottom diagram of the same column, you will see here, you can see the involvement of skin. If you see the yellow blocks, they all show us epidermis. And in pemphigus foliaceus, you have the involvement of this superficial layer of epidermis, where you can see the holes in the brown blocks. So this is the area of involvement of pemphigus foliaceus, and it involves only skin, but spare the mucosa. And if you go to the second column, which say PV, which shows pemphigus vulgaris, which is a most common type of pemphigus. And here you can see it shows the mucosa of the oral cavity. So this disease, this type of pemphigus, it involves the mucosa as well as skin. And here you can see in the bottom yellow blocks that you can see it involves the epidermis part, which is the involvement in the case of pemphigus vulgaris, and the antibodies against the protein which adheres the epidermal layer of the skin. And then we have paraneoplastic pemphigus. As you can see here, you can see there's an involvement of all the layers. Like if you can see, as I told you, the yellow blocks, which are which tells you about the epidermis. They are also involved in paraneoplastic pemphigus, as well as if you see just below the dark brown line, which is the area of dermis, it is also involved in paraneoplastic pemphigus. And at the end, we have bullous pemphigoid. As you can see, the name suggests the bullous pemphigoid. The name of the bulla is coming at first. So here, this is the type of pemphigus in which we have more predominant bulla, and here the involvement of skin and the antibodies are against the proteins which adheres the epidermal layer and the dermal layer. That's why the bulla, they are tight in case of bullous pemphigoid. So always in your MCQs, if you see most commonly in your exam, if there is an involvement of mucosa and the blister, they are flaccid, it means the involvement of skin is in epidermis. So they are the thin, flaccid, easily rupturing blister in case of Pemphigus vulgaris, but they are tight, tense, itchy in case of bullous pemphigoid. Why? Because in bullous pemphigoid, you have area of involvement of the skin which is more deeper. That's why the bulla in bullous pemphigoid, they are more tight and they are not easily ruptured. So as I said, the commonest type of pemphigus is Pemphigus vulgaris. And in this case, we have a blisters which are painful with the mucosal involvement, can be in oral cavity, and the bulla, they are easily ruptured. As we said, they involve the superficial layer of the skin, and then when they can easily rupture, as we are saying, they involve in the superficial layer of the epidermis, and then after rupture they leave the raw area there. And then we have another type of pemphigus, which is IgA pemphigus. It is a rare type of pemphigus. In this type, as the name suggests, the antibodies, again, as we said, antibodies against the adhering protein, but which can be different type in different type of pemphigus. And that's antibodies, those antibodies, their clinical presentation, they differentiate the different type of pemphigus. So in IgA pemphigus, as I said, antibodies are IgA. There are two different types of IgA pemphigus, which include subcorneal pustular dermatosis and intraepidermal neutrophilic IgA dermatosis. With regards to IgA pemphigus, it is associated with some of the disease, including multiple myeloma, MGUS, HIV, Sjogren disease, rheumatoid arthritis, and Crohn's disease. And these are some of the pictures here where you can see the type of the blister. Here again, if you see the pictures, as I said, that all the pemphigus disease, the bulla or the vesicle, they are superficial. So you can see you can see them, that these lesions, they are not big bulla, big blister, which we have in bullous pemphigoid. And this is the right one, most right, the screen picture. These are the picture of direct immunofluorescence. With regards to the exam, only they can show you the picture and asking you what type of investigation. I would say an MRCP one, they can ask the question. Then we have Pemphigus herpetiformis. So as the name suggests, herpetiformis, the lesions here, they look like the lesions of herpes. You guys must have seen the lesions of herpes on just around the lips. So the lesions looks like that. In this case, there are the urticarial plaques with vesiculobullous eruption, and which are in the form of herpetiform and annular pattern. And they are very much pleuritic. And the Pemphigus herpetiformis, there's an involvement of mucosa as well. And due to in the presence of eosinophilic spongiosis, they are also itchy, and they don't have the feature of acantholysis. Acantholysis is a feature of the Pemphigus vulgaris and Pemphigus foliaceus, which involve the most superficial layer because of the antibodies there. That's why these cells, they are separated easily only with the pressure, which is a sign called Nikolsky sign, that just rubbing onto the skin, superficial skin, either they are spread, or you can say you can increase the size of the blister because they are very much superficial on the skin. So this is the characteristic of the pemphigus diseases. Here you can see the features, the picture of the pemphigus herpetiformis, and these are the lesions which you can see. And then we have pemphigus vegetans. So as the name suggests, it is having the vegetative uh, and varicose and vortic like lesions, and they are usually just for keep in mind that these are present in the same wet humid area where we find the fungus, in armpit, in groins, and they are pustular in appearance, and they also can involve skin and mucous membrane. And if I will show you the picture, don't confuse it with another thing like which we have the pictures in the Cushing syndrome. This is a type of pemphigus which is called pemphigus vegetans. If the questions are asked about the skin disorder and they are giving you the options of pemphigus involvement of the area, humid area of groin and armpit, must consider pemphigus vegetans as one of your answer. As I said, paraneoplastic pemphigus, it involves all the layer of the skin. It can involve like uh, epidermis, all layer, and the dermis. It can have the blisters, which are in the type of the superficial layer of epidermis, like in which we can have pemphigus vulgaris and pemphigus foliaceus, as well as it can have the tens bulla, which involve the layers of epidermal and dermal layer. It can have tens bulla as well, and the most common diseases which are associated, and for the diseases with what it has got the paraneoplastic feature with the malignancy with what it is associated, they are most commonly lymphoproliferative disorders like non-Hodgkin lymphoma, chronic lymphocytic leukemia, and also paraneoplastic syndrome is a presenting feature of Castleman disease, which is a disease in which we have giant cell or angiofollicular lymph node hyperplasia, and which can be present in children and adolescents. Just for your understanding, and because we are mostly we are having the students, we are going for the preparation of the exam, that if the feature skin features involvement and the features of the pemphigus in young age patient with the lymph node enlargement, always think of Castleman disease. And here you can see that the type of the lesions, like you can see the actual involvement of the mucosa, the lesions, you can see the type and the intensity, how intense are these lesions. So these are the pictures of paraneoplastic pemphigus, where you can see involvement of the skin, involvement of the mucosa, and intensity of the lesions, which is in paraneoplastic pemphigus. As we said, pemphigus foliaceus. Again, let me remind you guys, again, this is a disease of the layers of epidermis. But again, if you want to differentiate pemphigus foliaceus with pemphigus vulgaris, as we said, if there is a mucosal involvement and the layer of epidermis are involved, then they are pemphigus vulgaris. But if the skin involvement and the superficial layer of epidermis involvement, then it is pemphigus foliaceus. And the blisters, as I said, they are fragile, often do not affect mucous membrane. So because I have seen quite a few MCQs asking about the questions which shows the blisters, just they ask the blister with mucosal involvement and without mucosal involvement. In the past, always this was understanding, and we had quite a few MCQs that without mucous involvement, it was always bullous pemphigoid, and with mucous involvement, we always thinking of Pemphigus vulgaris, but this is a differentiating point that if they are giving the easily flaccid, easily ruptured flaccid blister without mucosal involvement, then this is the type of pemphigus which is called Pemphigus foliaceus. It has got all the characteristics which we have in Pemphigus vulgaris. It has got a feature of keratinolysis, acantholysis, as we say, as I said, it is because of the antibodies against the adhesive protein of the epidermis. They can break down easily, and this is, and again, if we talk about that, this type of disease is more common in the New Zealand and Northern America. If the question asking about the area where it is more common, then it is New Zealand and North American. And here you can see the picture where they are showing the lesion, which are, you can say, most of them, they are now ruptured and they are on the skin area involvement. And the most common area of involvement in case of Pemphigus foliaceus, they are either present on the back, chest, and scalp, but no involvement of the mucosa, but the features similar to Pemphigus vulgaris. The disease is Pemphigus foliaceus. Then the type of Pemphigus foliaceus, then it can be because it can come because of the medication which involve penicillamine, nifedipine, calcium channel blockers, S inhibitor, NSAIDs, and also, as I told you, endemic Pemphigus foliaceus, it is common in South America, and where it is called Phogos salivagum, and it is transferred and it is caused by the virus which is transmitted by an insect bite. And another type of Pemphigus foliaceus, as you can see, the name suggests Pemphigus erythematosus. It has got the similar features like systemic lupus erythematosus, and it has got erythematous scaly crusted plaque, and they are present similar to systemic lupus erythematosus, involving the malar region of the nose, and they are worsened as like SLE by sunlight. And the immunofluorescence here, it demonstrates presence of IgG and C3 antibodies at dermoepidermal junction. And the management is also similar like SLE, but here we can use the less steroid dose, which is not as in the typical type of Pemphigus foliaceus. Then the other type of Pemphigus include IgA Pemphigus foliaceus, paraneoplastic Pemphigus foliaceus, and Pemphigus herpetiformis. And as I said to you, the area of involvement, face, chest, upper back, they are the most commonly involvement areas. There is no mucosal involvement. And pulla, usually they start, as we have seen in the picture, mostly they start onto the trunk. In some patient, the disease can resolve within few days without anything. For some patient, it can go to the long-term disease. In children, it can present as an arcuate, sarcinate, and polycyclic lesion. Sometimes there's an involvement of eyelid in case of Pemphigus foliaceus, and sometimes, sorry, it also has got the some sort of burning sensation and local pain. Remember always that most of the time the hard, tense pulla with the itching, it is characteristic of bullous pemphigoid, but sometimes you can have pain and burning sensation in case of Pemphigus foliaceus. But always with regard to the exam, common things are common. You always have to answer the itchy, tense, blister, and not easily ruptured bullous pemphigoid, easily ruptured Pemphigus. Diagnosis, as I told you, direct immunofluorescent test is the most, you can say, most confirmatory test, and it identifies the cell surface immune deposits, which includes throughout the epidermis. And It is also distinguish the different type of pemphigus as we mentioned earlier. So throughout the epidermis is a feature of Pemphigus vulgaris, but upper layer of superficial layer of epidermis, then it is Pemphigus foliaceus. And the antibodies here includes IgG in intercellular space, primarily in upper epidermis, again the feature of Pemphigus foliaceus. Indirect immunofluorescence. So if I talk about the direct immunofluorescence, in that case, we take the lesion, the blister with surrounding skin, and then we see them with the immunofluorescence, and then it gives you the pictures, which we shown the pictures in the previous slide, and also in the next slide we will see. In direct immunofluorescence, and it detects the antibodies in the blood, and here we use the substrates which include monkey esophagus, human skin, pig esophagus, and and these substrates, they increase the sensitivity and then distinguishing the type of Pemphigus. And if we differentiate, as I mentioned earlier, if you want to differentiate on the basis of direct immunofluorescence, Pemphigus vulgaris and Pemphigus foliaceus. So if you can see in case of Pemphigus vulgaris, we have IgG deposits which are throughout the epidermis, and if we say Pemphigus foliaceus, then they are present in the superficial layer of epidermis, but the antibodies in Pemphigus foliaceus, they can include IgG as well as IgA, as we have seen in our previous slides. The type of Pemphigus foliaceus also include IgA, Pemphigus, and the antibodies and the protein, as I told you, they are the protein which are in the cells between the cells of epidermis. Always remember Pemphigus foliaceus and vulgaris antibodies against the protein which adheres the epidermis. Again and again, I am saying this because this is an important point for differentiating from bullous pemphigoid. And then other investigation we can have by ELISA, but it needs the antibodies sensitivity of 98%, and then also we can do this investigation by immunoblast. Also histological examination we can use, but for definite diagnosis, confirmatory diagnosis, what is the investigation of the choice, and all these options, the answer is direct immunofluorescence. And the treatment, Sarah, do you want to ask something? Do you have any questions? So now for treatment of pemphigus, so for as we all know, all the skin disorder treatment, they start with the topic. I always say whenever we are going to start any treatment, whether whatever the system area of involvement, we always go with the supportive treatment and the treatment which is most conservative than invasive. So here in the skin, the first of all, for limited localized disease, we can treat with topical steroids and antibiotic like minocycline, tetracycline, and nicotinamide. And after that, we can use for the extensive disease, we can use prednisolone, and the dose can be 0.5 to 1.5 milligram per kilogram per day. And sometime we can only use steroid, and sometime we can use in combination with the immunosuppressant like azathioprine. And for the recurrent disease, also we can use rituximab, intravenous immunoglobulins, and as we know, to reduce the levels of antibodies. So in this case, the immunoglobulins are beneficial in the treatment of the pemphigus. Non-steroidal treatment include macetonin and anti-malarial therapy. As we all know, that one of the type is systemic lupus erythematosus. It is more effective in that type of pemphigus, in which we use anti-malarial with steroid. and some special. Obviously, these are the things and the type of the management which are always being decided by the dermatologist. But just for out of interest, we should know that these are also for our area of the knowledge, or with regards to the exam. I would say if we know the steroid, immunosuppressant, just we know the type of the treatment which we can do in case of pemphigus, it would be enough. But these are all the treatments which are decided by the dermatologist, which include photoprotection as well. Sometimes they can use plasmapheresis, but these are all. Thank you very much for attending the session. And if you guys have any question, I'm happy to answer here. Hello, if you guys have any question with regards to the topic, with regards to your MRCP upcoming exam, I'm happy to answer regarding them. If you need any guidance, how to, when, what time period you need for preparation of exam, especially with regards to MRCP medicine, Ireland and UK, how to prepare for exam. I'm here to answer you guys. I'm staying here for the next 10 minutes. If you have any queries, please you can ask and I can guide you how to approach exam. And welcome. And if you have any queries, you can ask me. You can come to me on our open group as well. If you have any queries with regards to the today's session, and if you have any queries and you want to ask us, we are also starting our fast track group in the end of December, on 20th of December, where I would be explaining all the MCQs, how to attempt them, what are the insight of asking the question, what is the diagnosis, how we approach the MRCP MCQs. We are starting on 20th of December and it will run until 19th of January, just prior to your exam. Either it is for MRCP Ireland and as well as for MRCP UK. You can always ask the questions. If you have any queries, I'm happy to answer now.